cataractcoach.com. All right, here, microphone working. Let's talk about some tough cases here. This is going to be all video. It's going to be very, very fast. Just hit play and don't touch it. Play and then don't touch. So first thing is watching for subtle signs here. Let me show you this video here. It's still not playing. Let's try again. There we go. So watch this. We have a very experienced surgeon here doing a beautiful rhexis. What a beautiful rhexis. Now this surgeon has done 10,000 cataracts already and is going to do a beautiful phaco chop technique. And I want you to tell me when you notice a problem. Watch carefully. Very experienced surgeon. So look at the phaco probe going in the eye. Good incisions. Beautiful rhexis. Starting off with the chopper. Look at the chop technique here. Beautiful chop. 1, 2, another chop. Look at that. So great. But wait a minute. 1, 2, 3. What? Why? So watch carefully. So removing the first 3 pieces, okay, nice and easy. Look at this piece. Wow. What happened? Why did the bag break? Of course, I blame the patient and the anesthesiologist. But still, what happened here? Look carefully. The snap sign right there. You see that? Look. Right there. Again, slow motion. That snap sign. This is a very obvious snap sign. Very obvious. But sometimes it can be very subtle. Today we have so many intravitreal injections. They've had prior macular degeneration, diabetic retinopathy, retinal vascular disease. They all get what? Intravitreal injections. And sometimes, especially the first-year resident, does the injection and hits the posterior capsule. So if you see the snap sign, this is a very obvious one, pow! That means the capsule is already broken wide open. So never forget this, because what's the problem now? You put the phaco probe in the eye, right? The posterior capsule is open. What's going to happen with high infusion pressure from the phaco probe? Come on, you know what's going to happen, right? You put the phaco probe in, infusion pressure is 50 millimeters of mercury, and then bye. Okay, right? Oh my goodness, what can you do here? So now watch this, another case, experienced surgeon, routine case, right? Capsular bag is clean, good looking rhexis, put some viscoelastic, and we're gonna put the lens in the eye, and watch carefully. Now the robot would already detect the problem, and I'll explain that a little bit later tonight. So here comes the lens going in the capsular bag. It looks pretty good, right? Okay, single piece of crystal, it's not upside down, it's correct. Okay, take it out the viscoelastic. And then it's just not quite centered. It's a little bit, whoa. Why? Who saw the problem? When I saw this video, I did not see the problem. I had to watch the video 3 or 4 times. But clearly there's vitreous here now. Clearly. Watch this. You come out of the eye. Look at the bubbles. Ready? The bag breaks here. Vitreous comes up. And look what happens to the bubbles. The vitreous pushes on the side. So subtle. You barely see it. And then you don't realize you put the viscoelastic, but the bag's already open. So again, things can happen in surgery so quickly, so easily, and it's so subtly. Here's another case. Routine case, okay. You're taking out the viscoelastic. It looks good. Beautiful rhexis. But what's the problem here? Do you know what's the problem now? The rhexis is behind the optic now. Do you see what I'm saying? Look again. Let me show you. The rhexis is behind. You have optic is in front of the rhexis now. It happened so subtly, so easily, quickly, you didn't notice. Watch carefully. Now it's behind. Optic is behind the rhexis. But when you let the AC collapse, look. Wow, now the optic is in front of the capsular rhexis. So again, little things like this can happen. You don't even realize it. So again, this is normal. This is not normal. That's optic capture with the optic anterior to the rhexis. So again, it happens so easily, so quickly. Look right there. Oh, now you're done. Done. So every little step can obviously pose an issue in cataract surgery. That's why even now, 40,000 cases later, I'm still learning. Now here's a routine case that I'm operating. You can see the radial keratotomy. What I do in these cases, and I made a big rhexis here, but it's still good, overlaps, 5.5 millimeter rhexis. When I seal the incision at the end of the case, just a little hydration, I will intentionally push the optic posteriorly. Push optic posterior to make sure it's behind the rexus. So we can take out the viscoelastic and angle sweep and then push the optic posterior just to make sure it's fully behind the rexus 360 degrees. That looks great. Watch carefully. Lens goes in the bag. Looks great, right? Let me show you again. The Sinskey hook grabbed the rexus and pulled out the whole capsule. Now, look, right there. There's the capsule. That's the capsule. Now what? Here's another case. Let's see, this is me operating. Lens goes in the bag. Let me see what we're going to have here. So you think it's a normal case, right? It's me operating. I'm trying to do a beautiful job here. And by the way, I show you all my complications on Cataract Coach, as you know. I like to show all the complications. So again, here we got the lens going in the bag. It looks like a pretty routine case here, right? Everything looks pretty normal. It's a toric monofocal lens, so we'll rotate the lens around just to make sure it's in the correct orientation. But there's still a problem. Got to get content for Insta. So now, look carefully here. What's the problem? Do you notice it yet? It's a very hard thing to see, but look, what? Look at this. That's humongous. Wow. I was going to leave that in the eye. That would cause inflammation for 1 year. So when the pupil is this size, 5 millimeter pupil, you need to lift the iris to check. So now I got to put the phacoprobe back in the eye and take out that last piece here. Again, you have to always check because these little tiny things. And the only reason I knew was because it just looked like a little bit elevated. Here's another case. It's me operating, lens goes in the bag, old video 6 years ago, 7 years ago. Rotate the lens, and now because the pupil's smaller, look, oh wow, look at all that. So I want to make sure the IOL is in the bag. Both haptics and the optic are in the bag. But also, is there cortex remaining? And clearly, in this case, there's a lot of cortex right up there. So put the phacoprobe in the eye, and let's remove that cortex, and maybe lift the iris up so we can see what we're doing here. Lift that up. Wow, all that cortex was left behind. So always check. And if you have a patient with a lot of inflammation 1 month after surgery, it's because you forgot to check. And I know because it's happened to me. So again, little things like this in surgery can be so subtle. Little things you have to be on the lookout for. And then at the end of the case, just a little hydration. We'll seal the incision here. Everything looks just great here. And this is an angle sweep just to make sure there's no viscoelastic stuck in the eye. So we wash all that out. And here's another case of me operating. And again, it looks pretty normal. Toric IOL in the bag, correct orientation. Everything looks great here. But again, where did that come from? Wow. So it's more common than we think. And so that's why at the end of the case, I like to do what's called the angle sweep. I use BSS on a 27 gauge cannula, and I sweep around the eye in the angle, under the iris even, and especially sub-incisionally. That piece rare was hidden sub-incisional. So you definitely want to always check to make sure you find that. So you can hear a little bit of a BSS angle sweep just to make sure. And again, patient can have a nice outcome, but we always have to check with that. So here's nearly impossible to see the piece. The piece is here sub-incisional. Very hard to see it. But when you do the BSS, wow, you can see that's the capsule equator. So this is what I'm talking about, the angle sweep. You can also remove all the OVD that you stuck in the angle by shooting BSS. And let me show you some great surgical pearls here. This will help a lot. Now I'm going to show you a few different pearls and you can decide which one is your favorite. Now the first pearl is, when you do a patient with a cortical cataract, do you know, before the rexus, you can move the opacities. It's just liquid. So you can push it with the cannula and clear the path for the rexus. So you can move the white cortical opacities out of the way. Look at that. You moved them out. Now you can see. Before you can't see. Here you can see. So it'll make it a lot easier. So you can do that before your rexus, move them out of the way. Now we can make an incision. I like diamonds because, well, I mean, we're in Beverly Hills. Beverly Hills is diamonds, right? So here we'll get a rexus done. And you see my forceps have marks at 2.5 and 5 millimeters. So when I do the rexus, I can always tell you exact size. And I have 3 femtosecond lasers, but this is what I call Cataract Coach femto. You just do it with your hands. And now we take out the viscoelastic, everything looks great. So here's the second pro. Second was when you do a chop, one chop, pull this piece out of the way. make room. So now I can just do one chop and then bring out the whole heminucleus because the chopper pushed the other piece out of the way. Let me show you that again. You can pull with the chopper this way to create space, and then the other half can come up and you can bring it up out of the bag. And at this point, it's a lot easier. So for a Beverly Hills cataract, one chop is enough. This is not a turkey cataract where you have to do 20 chops. We can just do one chop and we're done. It's pretty easy. Now, here's another one. So we got here. Oh, for the epinuclear shell, I like to flip it upside down. So we take out the last of the lens material. That's the nucleus. Here's an epinuclear shell. Grab it and flip it upside down. That's the easiest way to remove it, and it's safest for the bag. So grab here with vacuum, flip it upside down, and then you can get it out very, very easy. So again, epinucleus flip. So flipping the epinucleus up. And again, if you like all these, every video I'm showing you is already on Cataract Coach. So there it is, nice clean bag, and you're pretty happy here. So flipping the epinucleus really gives you an extra margin of safety here. And then patients obviously can have a very nice outcome. You certainly, when you're having patients paying for trifocal and EDOF lens, you don't want to break the bag. Let me share a couple quick pearls about CTRs also, the way I like to put a CTR in the eye. Now, if you see capsule wrinkling like you saw in the last lecture, this obviously means open the CTR. This is significant capsular excess weakening. So here you go. You can put a CTR in just with forceps. That works okay. And this is a resident who's doing a good case. I like to do this. Grab it with the Sinskey hook and deliver it with the injector. And then I move the Sinskey hook around the eye and then drop the whole thing right in the bag. It's just so easy to do. Pow, just like that. Now here's another patient who already had surgery attempted. They made an incision and everything. In fact, for the incision here, I'm just going to open it with my Sinskey hook or my spatula. Just open it right up. And so here in a case like this, we'll get a good 5 millimeter, 5.5 rexus done. And of course, we'll put a CTR in this eye too. Here's the CTR at the end of the case. We can deliver it in the bag, and then you can just follow it over and then just release it. Pow, it goes right. So easy to do. That's my favorite way. And I think CTR is great. Here's a brilliant idea from a young surgeon. He's a fellow today in Baskin Palmer, Miami. He's 30 years old. You can do this too. Putting a needle, the Sinskey hook, the capsule hook, iris hook in the needle, 27 gauge needle, and you put the collar of the iris hook on the needle. You can now go in, grab the pupil margin, and put just like one step. Look at this. I'll show you again. You put the iris hook inside the needle. I'll show you one more time here. You put the sleeve or the collar onto the needle also. Now you can just poke with the needle. No need to make a paracentesis. You can just poke in with this needle. I'm going to show you exactly how to load the iris hook into the needle in a second here. But you go inside here, hook the iris, and then you're just done. I think it's just a brilliant idea. And again, from a young guy, here you go. It goes in the needle. The hook goes away from the tip towards you. The sleeve the collar goes onto the needle. There's the hook. That's it. And now just poke in. Now, what do you do in a case like this? This is Beverly Hills, second eye. And I break the bag. Cataract coach, you're so dumb. Why did you break the bag? It's okay. I'll do a posterior rexus. So I try. And I'm not that good, so I don't get the rexus. I tried. I can't do it. I don't know. So what do? First eye has a toric trifocal. What do you do in this eye now? Put a monofocal? Sulcus lens? No. First, I'm going to get out the last piece of cortex, which I know is right there, because I remembered. I'm going to put the lens in the bag. I'm going to do it. The bag's going to open up a little bit, but it's still going to be stable. Ooh, the bag opened here now. But it's still stable. And notice I put it in so that the toric lens is lined up already. Now, the key is keeping the antihyaluronic base intact. Hydrate the incision first before removing viscoelastic. And now for viscoelastic removal, half the flow, half the vacuum, half. And now go in slowly and remove viscoelastic. Now you're saying, what about the viscoelastic that's behind the optic? This is why we have Diamox. Acetazolamide is your friend. Do not worry. So take out the viscoelastic from the anterior chamber, and then don't let the AC collapse, inject BSS, and now come out of the eye. And the patient does just fine. Don't worry. So this is a more common issue for me. Most experienced surgeons don't break the bag during phaco. It's during cortex removal because of some weakness in the bag. So here we go. End of the case, and it looks just fine. and there's no vitreous prolapse, anti-hard face intact. The lens is very, very stable in this direction, and the patient can have a beautiful outcome here. So again, these are just some great little pearls, tips, and tricks. I'm going to show you a lot more things, but thank you so much.